Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Increasing Specialty Care Revenue, featuring the Keratograph 5M and the Pentacam. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speakers tonight are Dr. Trevor Fosso and Dr. Jamie Kuzniar. Dr. Trevor Fosso graduated magna cum laude from Bethel University and went on to graduate from Michigan College of Optometry. He then completed a residency program through the Illinois College of Optometry in Madison, Wisconsin, focusing on anterior segment disease and contact lens management. Dr. Fosso currently serves as the Director of Contact Lens Services at Pinecone Vision Center. He is an active member of the American Optometric Association and the Minnesota Optometric Association, as well as the Fellow of American Academy of Optometry. Dr. Jamie Kuzniar received her Doctor of Optometry from the Michigan College of Optometry at Ferris State University. After graduation, Dr. Kuzniar completed a corneal disease and contact lens residency at Indiana University. She's the owner and founder of Elevate Eye Care and Eyewear in Rochester Hills, Michigan. Dr. Kuzniar was voted by Newsweek as number 15 on the list of top eye doctors in America in 2022. She is a fellow of the Scleral Lens Society, as well as the American Academy of Optometry. I'm excited for tonight's webinar. Take it away.
All right, well, thank you very much, Michelle, and thank you everyone for joining us tonight. Hopefully, like everyone else, you have some lovely weather just like I do tonight. It's finally not snowing in Minnesota, so that's nice. Yeah, so my name is Trevor Fosso. So I'm a doctor at Pinecone Vision Center in Sartell, Minnesota. We are a group OD practice, so there's 8 of us. We've got 2 different locations. And then we're a pretty heavy medical and referral-based practice. We do a lot of primary care, but we also get a lot of OD referrals as well from patients or from other doctors in the area. Just to kind of give you a little bit of background on myself. And then tonight for the webinar, I'm going to be focusing more on the aspect of things from the Pentacam side of things, whereas Jamie has more experience more with the Keratograph instead. So we're going to kind of be going a little bit back and forth in terms of how we use these 2 instruments each.
Yeah, and just a little background about my practice as well. So I'm actually in a cold start practice that's been open almost 9 months now. So I'm the only OD there. I do about 70% medical contact lenses at my office. So this is a question that I was really researching a ton a year ago, you know, which instrument do I choose for my office now that, you know, I'm the one making all the decisions, it's my money to spend, you know, which one is going to be the best for my practice. So I do a lot of contact lens fittings and I get referral sources from other ophthalmologists in the area. So a lot of times I'm more managing the contact lens side and I co-manage ophthalmologists that manage the disease side of the corneal conditions. So a little bit different than Trevor's practice. So kind of what our goals are is just to show you both sides, Pentacam versus Keratograph, I guess you could say, and how, just depending on what your practice style is, how you can best utilize both of these tools.
Yeah, and while both of these instruments, they provide just an insane amount of data, tonight we're not going to necessarily go into like the nitty-gritty details on understanding some of the scans and all the different things there. We'll get into some of that, but our goal is more to talk about, all right, how do we use each of these, you know, the different tests that they all do, where do we use them normally, and kind of how do we maximize, you know, kind of the reimbursement with these in our day-to-day. So I'm going to start off with, or kind of give us a quick background on the Pentacam. So the Pentacam is a corneal tomographer that uses a Scheimpflug image. Scheimpflug is probably one of my favorite words to say. It's just, I don't know, just rolls off the tongue well. But it's a great instrument, does excellent imaging of the anterior and posterior surface of the cornea, the lens, the anterior chamber. So it really is able to image the entire anterior component of the eye. You know, from the cornea to the back of the lens, we're able to image that. It's able to produce a height map, and based off of that, we're able to see, like I said, the entire front surface, back surface, pachymetry, front and back of the lens, anterior chamber, pretty much anything and everything you need to see from the front of the eye, we can image that with the Pentacam. For the Pentacam, there's 4 different models of the Pentacam. So there's the Pentacam, which is the standard. That is what we have in our office. So that's what I'm going to kind of be talking from a perspective of, is mostly using the Pentacam. They have the Pentacam HR, which is just a high resolution sensor. It has, I believe, about 5 times the resolution of the standard Pentacam. And then there's the AXL, which has that high resolution along with axial length and IOL calculation. And then their newest one, the Pentacam AXL Wave, which has that high resolution sensor, the axial length biometer, IOL calculator, as well as amberometry, retroillumination, and some other really cool tools that are very helpful. Just to give you an idea, so with the Pentacams, there's a lot of different modules, software modules, ways to interpret the data and utilize those. So this is just kind of a general overview of what all of the different models do. So they all do this. You know, they give us a general overview, topography, elevation, maps of the anterior and posterior cornea, pachymetry, shine fluke, all these different things. But some of the differences between them are some of these different modules. There's certain modules that come standard on like the Pentacam HR, the AXL, the AXL Wave that you can't get on or you can do as an add-on for the standard Pentacam. One thing that I'm going to talk about a little bit tonight and we'll get into is the CSP report, which stands for the corneal scleral profile report. That's available on the Pentacam HR. As a multi-shot image, whereas the Pentacam AXL has the CSP Pro, which is a single shot or a single caption image. And like I said, I'll talk a little bit about that later on. So just to get, with everything that the Pentacam does, it gathers all this really good data for it. What can we actually, when you're looking at it from a billing perspective and getting your return on investment, where can we use it? So the Pentacam is able to do a corneal topography, from a CS or a CPT code standpoint, 92025. It does anterior segment OCT. It does optical corneal pachymetry. It does external photography. And then we can use it for scleral topography with the Pentacam and the HR and the AXL Wave. And then with the AXL and the AXL Wave, it also does ophthalmic or axial length measurement, which again, I'm not going to get too much into that because we don't utilize that in our office, but it is available on 2 of these models at least.
And then I'm going to be talking more about the Keratograph. So the Keratograph is a Placido ring corneal topographer. So, but it also has something called the dry eye testing crystal tear report. So not only is it a topographer, like you can see anywhere, it also has this awesome dry eye testing. So it's able to do mybography, a non-invasive tear breakup, redness scale, tear height meniscus. And the way it does it is really cool. So when you're looking at the tear film dynamics, it's using white light. It's different than the white light that you're using on your slit lamp. So that's one thing, and I'll talk a little bit more about this when we talk about dry eye. A lot of times when we're in our slit lamp with our hot beams, I guess you could say, it can induce a lot of watering of the eye. It can kind of influence what you're measuring with the tear film. It's different with the Keratograph with how it uses the white light. It has blue for fluorescein images, and then it uses infrared for the mybography. You can also do anterior segment photos. You can do fluorescein photos and videos, which I use a ton for my contact lens fittings, and I love documenting that and communicating with my labs that way. It does pupillometry, and it's also wave compatible, just like the Pentacam is. So I love to utilize the wave software to design ortho-K lenses, corneal GPs, and everything like that. So what kind of tests can you build with the Keratograph? So obviously the number one is your topography, your external photography, then also mybography. This currently isn't covered code, but there is a code that's now being generated for mybography. If that's something that you choose to bill, just know that there's not many, and correct me if I'm wrong in the chat, insurances are actually reimbursing for that. However, that doesn't mean you can't bill for it. And we'll talk a little bit about that too. A lot of codes that we can use, what is reimbursable versus what gets passed along to the patient. But also with the Keratograph, something when we talk about return on investment with this kind of tool is you have to factor in your return on investment for your different dry eye procedures that you might be using in your office as well. If you have something like a LipoFlow or an IPL or a tear care or iLux, this tool is really critical to support your dry eye practice. So there's not necessarily a billable code for those things, but it is something else that it kind of assists that part of your practice hand in hand.
Yeah, 100%. We have a Keratograph as well in our other, so we have a Pentacam in one office and a Keratograph in the other office, and in that other office we have a IPL and a LipoFlow, and it plays such a big role in helping really kind of explain to patients just the patient education, which we'll kind of get into. So now we're going to kind of go through each of these different, each of the different tests that both of these instruments can do, kind of some of the differences with them, and kind of what we can get into. So let's see. So we'll start off with our corneal topography. So corneal topography, it's defined as either the unilateral or bilateral with the interpretation report. That's what the 92025 code is. It gives us a detailed map of the physical features of the anterior surface of the cornea is really what it's focusing on. So it's not posterior surface, but corneal topography is defined as looking at the anterior surface primarily. And the goal, in terms of billing this, it has to be used to diagnose and manage, different corneal diseases, disorders, abnormalities, injuries, blurry vision, different things like that. So some common examples, Jamie and I, this is something, I use the Pentacam every day except Tuesdays, because Tuesday is the day that I use the Keratograph, because that's when I'm in my other office. But I'm sure, Jamie, you probably use it, every day you're in the office, you're using your Keratograph. It's something, it's my favorite instrument in my office anyway.
Yeah, and I use mine every day, and I know I'm a specialty lens practice, but I think there's a lot of primary care offices that a lot of times we think we only need to use the topography for keratoconus, but I mean, use that if someone has, post LASIK and you're wondering if there's a little bit of ectasia. Use that if there's blurred vision and you don't know what's causing a reduction of, best corrected vision. Use that for scarring. There's a lot of different things that you can use it for, and it can really shed a light on really minor, early diseases of the cornea. So don't be afraid to reach for that tool, just like you would with an OCT. Like we run OCTs all the time and we're not sure what's going on, but sometimes we forget to run the topography.
Yeah, I mean, especially like, if I ever have a patient who comes in and their complaint is blurred vision, the two tests I run on every single one of them are a Pentacam and an OCT of the macula to take a look and see, is there something funny going on there? So we're just going to go through, some of the different modules that the Pentacam has, because again, the Pentacam has so many different ways of interpreting the data that you can get from one scan, that again, I'm not going to go into extreme detail on too many of them, but I just want to show you the kind of the main four that I like to utilize. The first one that pops up is just the general overview scan, and again, it gives you a nice general overview, exactly what it says. Gives us a nice little shine fluke image where you've got that nice cut through, kind of a model of the cornea, and then what I like to look at, kind of our heat map of those high and low areas, looking at that axial map. And you can go in and change the axial map in that drop down to tangential, elevation, front surface, back of the cornea, front of the lens. You can look at these maps kind of everywhere. It also gives you just your SIM-Ks, looking at orientation, eccentricity, everything, as well as giving you pachymetry measurements, which we'll get into, and anterior chamber measurements, which again, we'll get into as well. So, but this is just an example of a patient, actually a gentleman that I saw earlier this year in January who came in just for a LASIK consult, and he comes in for a LASIK eval, and he's someone, I take a look at this, and we can all look at this left eye and say like, hey, it's at least a little heavy on the bottom. That's a little funny looking. So whenever I have something like that, and for all my LASIK evals, the next scan that we go on to, or the next interpretation that we go into, is the Bell and Ambrosio enhanced ectasia. This map is another way of again looking and using at that topography to really understand and highlight areas of abnormality. I don't use this test to really diagnose someone with keratoconus, because you can have abnormal results on here with really thick corneas, really thin corneas, patients who have really large HVIDs, really small HVIDs. They can all look kind of funny on this map. But whenever I have this and something gets highlighted, I'm always looking at it. But to give you just a little background of what this test or what this module is really looking at, is it gives us a measurement of looking at the elevation of the front and back surface of the cornea. And it compares the elevation measured on this patient to a best fit sphere, and that's in the top. Then in the second one, so in the middle, what it does is it highlights in that kind of red circle in the middle, it highlights the area that's kind of considered the most abnormal, ignores that, creates a new best fit sphere, and then recalculates the differences off of that new best fit sphere. And then in the very bottom, it just does a subtraction map from the top to the bottom. And if there's a big enough difference, that's where we get flagged as yellow or red, as, hey, this is at least suspicious and we probably need to look at it a little bit more. So just to give you an idea, that's what it looks at. It's really good at picking up subtle, very early changes that look suspicious. And when I have those, then we go on to kind of our next maps. You know, I like to look at the 4 maps refractive map. Again, gives us our axial map, looks at elevation of the front of the eye, elevation of the back of the eye. I like looking the axial map on this one as compared to the general overview, because it gives us the meridians, and you can really see on this patient how those, you know, especially the steep axis starts to bow quite a bit. And again, that there, you know, in this patient, you know, that inferior steepening, we're seeing that bowing. That's all suspicious of keratoconus. So that's, you know, really what we're digging into. And again, you know, we also get corneal thickness. I like looking at the K max value on here, which is down in kind of the lower left-hand side of the printout. But again, just gives us a ton of data on here. But I like these 4 maps, looking at those together. And then when I have somewhere I'm really, you know, like, oh, this really looks like keratoconus to me, then they have this nice topometric keratoconus staging, which looks at front and back surface curvature of the cornea. Because really, for our diagnosis of keratoconus, we have to see, you know, anterior abnormality, posterior abnormality, and a change in global pachymetry. So an abnormal change in global pachymetry where there's an abnormal thinning. So it doesn't show us the pachymetry map, but it focuses on that front surface and posterior surface. And especially on here, if we look at that axial of the back eye, that inferior steepening where you get that slightly darker blue on the bottom, that's again a little heavy down there, that is characteristic to say, like, yep, this guy has very mild or very early, you know, we could say form frost keratoconus, you know, that we're picking up with the Pentacam here. So just the amount of data you can get and utilize with the topography is just fantastic. And I, you know, love it. You know, even on days when I'm down at my other office and we have the keratograph, I have so many of those that I'm just, you know, not quite sure. You know, he would have been one that it's like I would have gotten that scan on him, and I'm just like, I'm just not quite sure. And then I just get him scheduled back at my other office to get a Pentacam so I can look at this, you know, a little more detailed topography, and it's very helpful for that. Jamie?
There you go. I was waiting for you to change the slide. There you go. So I won't go into as much detail with the keratograph, but what I usually look at with most of my patients, so the first one looking at my tangential map, I like to look at the map along with the image of the eye next to it. And it's a little different when you use a placebo-based topographer because I always like to look at what kind of image is going on with the eye and with the map that I'm doing. So I like having that image of the eye next to it. It has a lot of the same similar kind of data that Trevor looks for. What I look for a lot is looking at obviously my Ks, my eccentricity. I like to look at my HVID, which is on here, or you can measure manually. And then what's highlighted in red is a TKC. So it's kind of like a grading of keratoconus. So this is a patient obviously with keratoconus, and it auto graded it as a 3. And that's on a scale from 0 being nothing to 4 being the most advanced. If you go to the next slide. The next slide is just more of my axial map. So I like to use that more when I'm actually doing more lens design, communicating with the lab. And then next slide. And then my elevation maps as well. So it's important to note with the keratograph, you are looking at elevation, but it is the anterior elevation. So you're not getting those posterior float changes like you are with the Pentacam. But I'm more so using this to see, because I do a lot more lens design, I really want to know what are the high points and low points of the cornea. So if I'm fitting a corneal gas perm or a scleral lens, I want to know exactly what am I looking for, what kind of fluorescein pattern do I expect, what kind of lens should I fit on this patient. And then next slide. And then this here is something kind of similar to what the Pentacam has. This actually can help to track the progression of keratoconus. Again, just looking at the front surface of the eye. So it goes through a number of indices, which we're not going to talk about in this lecture today. But it can actually do a series on the bottom every single time that they come in, and you can see if they're actually showing a little bit of progression. If I am seeing things change and progress on here, if they're already not being co-managed by a corneal ophthalmologist with the Pentacam, I am really getting on them that, hey, things are changing. I really think you need to go either getting considered for cross-linking. Let's go get some Pentacam images, because I think these two topographers really just work hand in hand. Not every practice can have a Pentacam, but the Keratograph does a great job to monitor for changes and lets you know when you do need to send out for that type of topography. And then next slide. The next thing is our comparison maps. So I do that a lot with Ortho-K. So as you can see in the image here, I'm doing a comparison map of the baseline versus after a week of treatment for my patient. So using a tangential map, I'm literally looking at where is that treatment at, and it actually projects it onto the front of the eye with the image that they took, which is pretty cool. So a lot of times I'll actually show that to the patient and the parents, and I'll say, wow, look at that really awesome, bullseye treatment zone. The lens is perfectly centered on his eye when they're sleeping. That's why he's having such great vision. And then next slide. And then I like to do the refractive baseline versus 1 week, 1 day, what have you. And you can actually hover over that scale and see how much diopters of change am I having. So if I'm correcting a patient that's maybe a -4, I want to make sure I'm actually getting a -4 treatment. I'm not getting a -5. I'm not overcorrecting that child, and I'm not undercorrecting. So that helps me a lot if everything is centered, but something's not making sense as to why they're not seeing as well. I like to use that refractive map. Next slide. And so looking at topography, just like Trevor was saying, you really need to have a medical reason. But the 2 on the top, I was going to ask you, Trevor, do you usually bill, like, encode irregular astigmatism? Do you get paid on that?
I do. So
yeah, so nervous to call that, because with lenses fitting, they tell you not to ever.
So for billing lens purposes, like, yeah, you usually have to have, like, especially for like medically necessary contacts, you usually need a underlying cause for that irregular astigmatism. But for billing something like a corneal topography, you really don't. So because you maybe just don't know what's causing that irregular astigmatism yet, but it's irregular. So
yeah, and that makes sense. So there's a list here. This obviously is not every single condition that you can bill to Medicare, but these ones are the ones. If you're coding something like this, these claims should be paid by Medicare, most of the other commercial plans as well.
Yeah, and again, there's so many other things, like, nearly every doctor, optometrist, ophthalmologist uses corneal topography, or could, almost every day. There's so many different conditions that we can use it for. I never have an issue not billing it under something, and again, we'll kind of get into that to kind of give you an idea in terms of, like, just this is Medicare's, a Medicare reimbursement, and this could vary, depending on the state that you're in and even the location of the state that you're in. But Medicare reimbursement is around $37. Most Other insurances are somewhere between that like $25 up to about $50, $55 for a topography, just so you know kind of what what to expect with that. As for like repeat testing, because for me, especially keratoconus patients, we're doing topographies. Jamie's talking about tracking them, doing them over and over. Again, billing those every time they come in. They do kind of make a little caveat of saying, repeat testing is only indicated and covered if there's a change in vision. Well, I mean, oftentimes with many of these conditions, the only way we're going to see that change is with the topography. So I don't have much issue with it in terms of getting reimbursed on it. Even if their vision there's usually a little bit of change that we don't run into issues there.
Or if a patient perceives there's a change. I had a perfect example today. Yeah. For example, I had a patient I fit in sclerals a month ago, and she came in, and I'm sure we hear this a lot, is I have a problem. I don't see as well without my lenses now ever since I started wearing these. And she was insistent that, the scleral lenses had ruined her unaided vision. And so I just did, I said, well, let's do another scan. We did another scan. I compared it to baseline, and I actually did a side-by-side comparison map to show like her cornea hadn't changed. And we all know it was likely just that she had neuroadapted to the clear vision of scleral lenses, but it was a good way to show the patient, like it was a concern. That was her chief complaint of coming in. And you can run that scan and you can show us side-by-side that there wasn't a change. So even though there wasn't a change, there was the chief complaint was the patient was concerned with it. And so that's another good, that's legitimate to bill for that.
Yeah, they're coming in complaining of blurry vision. We're doing a test to figure out where that blurry vision is coming from. So kind of an extension of topography. So the Pentacam CSP report, I think of it as kind of like I said, an extension of topography, because really you're kind of getting a topographical map of the sclera. It can map out to 18 millimeters. So with the standard CSP, it's 5 images. You do one straight ahead, one looking up, down, left, or nasal and temporal. And I'll show you what one of these scans looks like. With the CSP Pro, we're able to get that whole image all in one shot. And even on someone like me who has pretty deep set eyes, they proved me wrong and they could get the whole scan in one shot. I think when we were at ICSC a couple of years ago. It is, so like I said, it is considered kind of an incidental service. So there's not a separate CPT code for scleral topography or for the CSP. So there's not a separate billable code for it, but because it is an extension of corneal topography, you can utilize the 22 modifier. And this is something I use when I'm working with my scleral lens patients. On all my new scleral lens patients, my technician gets a CSP scan on every single one of them. And so when I bill topography again at that appointment, I add a 22 modifier on there, which is for increased procedural services. This is for a service that kind of goes above and beyond the typical framework. When you're going above, more than what you typically would have to do. So this is more than a standard topography. It increases the reimbursement. There's a couple of situations, rather than looking at all the situations you could use a 22 modifier, I thought it was a little easier to look at when not to use one. Basically, you don't want to use a 22 modifier when there's already another CPT code. If I was using this to look at topography and then do an external photo, and I was using a 22 modifier for the external, because I did a photo, well, that's just not the right spot to use it. There has to be additional work that's not separately reimbursable. So again, like there's not another code for this. And this is something that, it's not like I feel like this is a little bit of a gray area because it's coming from the physician's choice, but I'm not necessarily choosing to take all these extra. I am in some degree, but it's for a medical purpose to help with that scleral lens fitting. And so because it's kind of considered part of the contact lens fitting, part of that, it's not a separate code, but utilizing and remembering to use the 22 modifier, which usually pays about 1.5. So you'd pay about $50 rather than $37 for the 92025 with the 22 modifier on there. This is just an example of what the CSP image looks like. So you can see there's a coverage map right in the middle. and that has the gray spot in the middle. That's the standard scan, and then green is superior, red is inferior, purple nasal, and blue is temporal. And then it just takes that scan, maps them all together, and then you can use this to figure out your best starting lens. You can measure sags at different core diameters. You can also take and export all this raw data, which exports essentially as like a giant Excel spreadsheet, and upload it to do freeform lens design, all sorts of different things that you can do with it. But it's really helpful in terms of just improving the efficiency of scleral lens fitting. Sometimes figuring out that the scleral alignment can take such a can be such a headache for some patients, and that can really really help quite a bit there. Another test, so the Pentacam does, so the Keratograph is not able to do this one, but it's optical corneal pachymetry, and we have to emphasize the optical here. So the CPT code for pachymetry is for ultrasound pachymetry, so 76514 is for an ultrasound pachymetry. The Pentacam is an optical pachymeter. So technically we're going to actually use the 92499 code, which is an unlisted ophthalmological service code. And then when you submit that to insurance, you can kind of put with it an explanatory note saying this is optical corneal pachymetry, and then it still will pay. It only pays about $12 is what this what the ultrasound code pays. So it doesn't pay a ton, but it gives us such good data. I mean, you can see on this patient here, he's got this is a patient of mine who, if I remember correctly, he's aphakic, microcornea, has severe edema, has been holding off on a transplant for a long time, but you can just see that whole global pachymetry, upwards of 1,000 to 800 centrally, and just gives you that really nice range. I love using this on patients with like corneal ulcers, so I can track those. Glaucoma patients, we can obviously do a glaucoma or a pachymetry measurement there. However, that one typically only reimburses once per lifetime for the patient, unless they're changing for another reason. But if you're billing it strictly under glaucoma, it usually only pays once. But conditions like keratoconus and other ectasias, pre-LASIK evals, post-LASIK monitoring, post-op corneal transplant monitoring, corneal edema with Fuchs, corneal ulcers and melts, we can see how that pachymetry changes and really monitor that. So for me, it's again another really, really helpful tool that I utilize a lot.
And then moving over to like external photography. So that's something that I utilize often, almost maybe even more or almost just as much as my typography with the Keratograph. So when you're looking at having this for coverage, so what I use it for a lot is for tracking disease progression. Okay, so it needs to be able to aid in the diagnosis and treatment. So you're not just taking a picture of the same thing over and over and over for no reason, really using it for disease progression. So I like to use this on my graft patients, especially if they have any sort of neovascularization. Before I'm fitting a lens, I'm doing a photo on them, because I want to know as they're wearing the lenses over time, especially scleral lenses, just to make sure if they're starting to show any kind of haze, any kind of neo, I can really do a side-by-side to say, like, has it really changed and how much has it? And I explain that to the patient, and I tell them, and I show them certain areas that I am concerned with and looking at before we even start the process of fitting a lens. And then we follow up with that every 6 months to a year, depending on what the condition is. And then looking at the two different instruments, so with the Keratograph, you can do iris images, you can do cornea images, and then you can also do fluorescein images. So that's one of my images on the top there. So I love the fluorescein images that it gives me, especially when I'm doing dry eye assessment and management. So it's really tough with dry eye, and we'll talk about this in a couple of slides. A lot of times patients, especially if they're neurotrophic or they've lost sensitivity, they don't really take their disease seriously. But if you actually can take a picture and say, look at all these micro cracks on your eye, look at all this, it's called SPK. We really need to heal this. And you can do a baseline photo, you can do a photo after implementing any kind of treatment that you want to really show, is that getting better? Is it not? Is it worsening? So I use my fluorescein images all the time. The Pentacam does it a little differently. Do you want to talk about that, Trevor?
Yeah, so the Pentacam imaging, so it you can do an external photo. We'll get into, there's kind of like, I feel like some crossover between the external photo and the anterior segment OCT kind of billing codes. But you can do a single Scheimpflug image is technically considered an external photo, whether you're looking at the angle, if you've got an ulcer, something like that. You can consider like an iris image or a corneal image. Like for example, the patient or the image on the bottom is a patient who has lipid keratopathy. It's hard to appreciate on there. You can use it as a photo. I think it's better used actually as the anterior segment OCT, which we'll get into more. But yeah, when it comes to photos, and Jamie's going to go into a lot of these. The Keratograph, like I said, I use it every Tuesday. The dry eye eval report is, once you figure that thing out, it is such a wonderful tool with so many good images.
Yeah, and the other thing I like to use it for is my contact lens fitting. So there's a lot of really cool camera tools that are built in to the software. So this is an example of a scleral lens patient that I'm going to be doing a microvault on. So when I'm doing a microvault, I want to measure a lesion that I'm going to have to vault over, so I can exactly measure how big that needs to be. You can actually put like a radius there, and you can actually measure the exact rotation of where the lesion is compared to the lens, compared to if there's hash marks on the lens. Because before I was always using my slit lamp to do these things, and it's a lot more guesswork. But once you start really digging into these tools that you have within the Keratograph, you can get a lot more precise with a lot of your contact lens fitting. And then if you go to the next slide, you can also do fluorescein images like you can see here. So I have an image of a patient on the left that had came in. He was wearing a habitual gas perm lens, an RK patient, and the lens actually wasn't moving at all when he was blinking, and that circle in the center was actually this like air pocket that had formed underneath the lens. And when I took that lens off, it actually was like an indent in his cornea. It was pretty wild. So I was able to take a picture and kind of show him, like he was actually pretty happy with his lens, but I had to say like, listen, this is what I'm concerned with. I don't like your lens doesn't move. I don't like this little air pocket here. And then refitting the lens on the right, I actually did a wave freeform lens, which was pretty cool. So I designed a wave freeform lens because his eye was so irregular. And it gave a lot more of an even fluorescein pattern. And when you could see it, it was actually moving. It was a lot more healthy for the patient. So you can always send these videos, you can do photos, you can send those to your lab, you can send them to your consultants, and it's a really great way for them to assist you too, is if you're getting into sclerals or gas perms, it's a good way to really start learning as well. And then
yeah, I would say, videos are great. If a photo's worth 1,000 words, a video's worth like 1,000,000 when it comes to contacts.
Yeah, and these were supposed to be videos, but the file did not work. And then looking at pupillometry. So I use this when I'm designing multifocal optics on custom lenses, whether it be custom soft lenses or scleral lenses. It's actually really cool. So it uses an infrared camera. So instead of just in your exam lane trying to measure the pupil size, which I'm always like, that's so hard from office to office and room to room. Like, how do you know what the illumination is? This is actually using an infrared camera, and it's going to measure the exact pupil size. And then it actually goes through and it will like flash a light. So it will show you the minimum and maximum that the pupil gets through a series of flashes. So you can truly see what the pupil is in dark and dim illumination if you're really trying to get that really precise custom multifocal. So I do a lot of custom multifocals, and to me, this is a tool that I like to use to get a lot more precise measurement for my patients. Not billable, but really cool. And then next, we're going to talk about the dry eye assessment. So this is a big part of the Keratograph. Just like Trevor says, he uses it on Tuesdays specifically, but I use it daily. My advice, when you're doing dry eye assessments, always have that patient back for a medical dry eye assessment. Okay, there's a lot of great tools in here. Don't do them to your routine exam. That first of all, it would be a really long exam. But second of all, this is a medical condition. So a lot of times if someone's complaining about dry eye, if I'm seeing signs and symptoms or issues with a survey that they took, then I'll have them back for imaging. And usually you can bill like a level 3 or a level 4 for this visit, depending on how much time and all the elements that you're doing for your exam. You can also bill for the external photos. And it really just gives you a really great baseline for what is going on with the patient. And you can decide, what type of dry eye does the patient have? And that's what I explained to them. If I don't do this assessment, I'm just going to be guessing and throwing different types of drops at you. I want to really know what is causing your dry eye. Is it an aqueous problem? Is it an oil gland problem? We're really going to figure out the root of the problem. And my patients actually love that. They're like, that is great, because in the past it was like, here, try this sample, try that sample, and then it doesn't work and they don't ever come back. So it really buys them into, we're ready to commit to this dry eye therapy. And then we're going to go through a couple of the images that I like to use next. So the different reports that we have, there's a tear meniscus, which is a great way to measure tear height instead of doing a Schirmer's test. Doing a non-invasive keratograph breakup time, which is a non-invasive tear breakup, redness scale, a lipid layer scale. It has OSDI factored into the report, mammography, and then I'll show you a little customized report that you can print for your patients as well. So starting out, the first one is the tear meniscus. So this is looking for if you're having issues with an aqueous deficient dry eye. I personally don't do Schirmer's anymore. Do you do Schirmer's anymore, Trevor? You look like someone that would do Schirmer's still, huh?
Wow.
Just joking.
No, I don't do Schirmer's.
Don't do Schirmer's.
We do phenol thread tests instead.
Oh, do you? Okay, so you can do phenol thread. That's totally fine. I'm not trying to knock on Schirmer's, but I just prefer this better because it's non-invasive. It's the patient's just looking straight ahead. They blink normally. You can just really measure how much tears they're making, and you can track this from pre-treatment to if you're studying them on something like cyclosporine, 4 weeks in, 8 weeks in, 12 weeks, what have you, to really see if their tear volume is improving or not. So this is a really good image that we do for a lot. But the next test is actually my favorite test. So the next one is the non-invasive tear breakup time. I love this. This is my favorite test on the keratograph. Okay. Because the graph just really shows exactly what is going on to the patient. So what it's doing is it has the patient blink a few times and then look straight ahead, and it's actually taking a video, and it will show you exactly where the tears are breaking up, and it tracks the first breakup, the average breakup, and it puts it all on that map. So this is a huge impact for my patient. I will literally take this test and I'll just turn the screen over and I'll show them and say, do you ever feel like, you have to blink your eyes a lot, like every few seconds? Look, your tears after about 5 seconds are starting to evaporate on the front of your eye, and I show them the video. And they're like, wow, that's exactly what is going on. And then if you look at the next slide, what it also can do is it actually does comparison maps. So I always have a baseline. This is why I always like having a baseline before whatever treatment that we do. This is important for a few different things. One, because, it shows that there's a need for a problem. And two, once you get to after your treatment, a lot of times it's hard to remember when you have dry eye exactly how you felt 8 to 12 weeks ago. Like, I don't know, they're still kind of dry. Did that procedure work or not? So this is a patient example of a baseline all the way on the left. The image in the middle was after a LipiFlow treatment, their first one. Okay, so your tear breakup went from an average of 8.5 seconds to almost 13 seconds after the LipiFlow treatment. And this was a person where they're like, I don't know, I don't really think it worked, and you can still them and say, actually it did. I'm really happy with it. Your eyes look great, your tears look great. And then that patient decided to do a second LipiFlow the next year, and their scores just continue to rise. They went to 15 seconds for their first breakup, 17 seconds average. So it really just showed once we keep doing these dry eye therapies on an annual basis or every 6-month basis, that we're going to keep having improvement. And the proof is right here. Another interesting thing too, not to plug like tear care, but they just had this new guarantee that they launched where if, and I'm explaining this to all my patients, if they do a tear breakup and if within 4 to 6 weeks, if that is not 50% better, they will give them a free treatment, second treatment. And so I'm telling my patients that, like, listen, if this doesn't work, we'll take the images before and after. This treatment is guaranteed to work, and if it doesn't, they'll give us a second one for free. And the best way to do that is just using the keratograph for that. So it's pretty interesting way to kind of capture a lot of your patients there as well. And then going on to the next couple tests, these ones are a little bit more straightforward. So this is a redness scale. I like to do this just to document how much redness that there is. A lot of times it looks redder to the patient than they're used to because they're not used to seeing their eye magnified. I just kind of use this to track from grade 0 to grade 4. Not the most important test, but I still like to have it. And then looking at the next one, we have.
Well, I also, just real quick, I love on like this one too, like when you get the lid photo, the patients look at that and they're like, oh my God, those are my lids.
Oh, the lids for the redness scale?
Yeah.
Oh.
Yeah, well, like because they can see the like the oil glands, like the edges of them, things like that, or like looking at the lashes more. So
I'll start pointing that out to them. And then of course the biography, like this is another huge one. Like this one and the tear breakup, those are like the #2 money shot. Like, I mean, it's just looking at the glands. Like I just had someone this week, he was in scleral lenses, he was still having some issues with dryness. So we did my biography on him and I showed him like he had 50% atrophy. And I said, you know, your glands are dying. And he goes, oh my gosh, my glands are dying. You make that sound so awful. And it is awful. Those glands have atrophied. We need to do something about it. You can offer the treatment plan, but until you really get an image of it, it's hard for patients to really understand like what the heck is going on. Why do I need to do any of these expensive, you know, dry eye therapies when my eyes are just mildly bothering them? So this is really, really important if you're doing any type of dry eye treatment. And then talking about, you know, just return on investment, a picture like this, it might only reimburse you like $25, but if you can get a picture like this and convert a patient from being skeptical about their dry eye to doing something like an IPL, I mean, we all know the revenue on that is so much higher. So your return on investment and your overall practice will be a lot higher because you're converting these patients to doing the dry eye therapies that they need by just showing them images. And then next, I think I'm going to show you the reports. So these are pretty cool. You can actually customize the report with your practice logo at the top. And then as you're grading the patient, it'll actually grade them and you can program it to have your own specific plan to based on what your practice likes to do. So if they have, you know, a reduced tear breakup, it'll automatically talk about using like warm compresses or lid hygiene, whatever you want to do. And then that way it'll automatically populate this plan. You can print it out, you can give it to the patient, that way they can take it home, because we all know when we're talking about dry eye, it seems like we're implementing a lot of things at once. It's a ton of information for our patients, and it's good to send them home with something so they can look at it, really absorb it, and a lot of times talk it over with their family if they need to. So this is a really great tool that's just built into the Keratograph. It's called the Crystal Tear Report. And then what is next?
yeah, so with the, you know, the photos, you know, like there's so, you know, just about anything you take a picture of, you know, falls underneath some type of external photo. And like Jamie said, you know, the reimbursement isn't, you know, amazing, but, you know, $22 roughly. But just the patient education, getting them, you know, some buy-in on, yes, I need to do something like this, or just to be able to have them better understand what's going on is, you know, such a helpful thing, whether it be, you know, the front of the eye or the back of the eye. It's just very, very helpful that way. Like I said, kind of, you know, I feel like there's some similarity, but the Pentacam, the last thing that it does that we're going to kind of touch on is just it technically does an optical tomography of the anterior segment. So it is an anterior segment OCT. You know, when it's examining the structures of the anterior segment, you know, the cornea, anterior chamber, iris, lens, everything like that. This for me has honestly become such a helpful tool for looking at narrow angle glaucoma suspects, looking at, you know, angle closure, you know, especially just, you know, whether it's, you know, if I don't have an anterior segment OCT, this is something I can add in and it's super helpful for that. You can also look at corneal edema and opacities just with cut throughs. And what that looks like is, so the Pentacam, it's getting 25 of these, you know, Scheimpflug images, and each one of these is an anterior segment OCT image. And this is just, you know, this is what all 25 of theirs look like. You can just kind of see all those different cut throughs at all those different angles. This is just like, you know, like I said, it's fairly straightforward, kind of what we see with that. This is an example of a patient of mine. She's about a +6. This is her before cataract surgery. You can see her anterior chamber, super narrow. The Pentacam actually gives you, this one doesn't have the patient data covered up, my bad. I don't know why, but that's all right. But it has the anterior chamber volume is only about 50 cubic millimeters. And then the angle is at about 18 degrees. And then after cataract surgery, she about doubles in volume and the angle is now 45. So it's really cool that you're able to compare that a lot easier, especially for someone like me whose gonioscopy skills are, I don't know, we'll say sketchy at best. This is a really helpful tool for me, and again, something else that we can code for these patients. And especially, like I said, there's a little bit of a kind of some overlap with photos there, possibly. The reimbursement's a little bit better, about $32 on this, so you're kind of able to add that on for all these different things. So one thing we wanted to just put in at the end here is, if we're looking at strictly from a CPT, billing standpoint, insurance reimbursement standpoint, here's everything that the Pentacam can do, and here's everything that the Keratograph can do. We've got the topography and the external photos and the mybography. One thing that like I talked about with using the CSP, like I said, I use the Keratograph every Tuesday, and with all those photos that I take, I usually put a 22 modifier on that external photo because you're taking so many of those photos. That's more than your standard photo and the interpretation that goes with them. So again, you can increase that reimbursement there, but you can just kind of see the differences there of everything that you can do. Granted, like I said, with the Pentacam, it's a little questionable whether or not you do both the OCT and the external photo, but almost every time I do an OCT, or a Pentacam, I am billing the top 3 on all 3 of those with that one.
Yeah, and it's really interesting too. I mean, the whole point of us doing this lecture is, like, Trevor and I like to argue, like, we both love our instruments. Like, they're both great, and they can both be really productive for your practice. It just depends on what type of practice that you have. So even though, the Keratograph might only make like half the amount of production as the Pentacam, it's like looking at that extra dry eye feature as well, and how does that build your specific practice if you're more dry eye focused or versus more disease focused like Trevor is. And something that we talk about too is, just because something isn't covered doesn't mean you shouldn't do it. And I think a lot of times as optometrists, so many of us are guilty of, like, I don't know, something looks a little funny, well, let's just run a macular OCT, but I won't bill for it. Or something looks a little funny with the cornea, I'll just run a topography, and if it looks good, I'm not going to bill for it. You're investing in these tools, you're investing in your practice, you're investing in yourself by being able to interpret those scans to know that there's nothing wrong. So bill for it, and it might not be covered, but as long as you're informing your patient why you're doing it, I think that's totally legitimate to do. It's not like you're doing something that is unnecessary for your patient. You're not scanning everybody, doing a topography on every single person that walks in the door. But if you're using this as needed, don't be afraid of pushback by the insurance if it's something that's not covered, to pass that along to the patient if it's really for the goodwill, of the patient and their eye care.
Yeah, so then it comes down to the question of if you're on the fence, hey, which one do I choose? Like Jamie already said, it really comes down to like what kind of practice are you in? For me, like I said, I'm lucky enough I have access to both. But if I had to pick one, I would pick the Pentacam every single time because I just love all the data it gives me. But the Keratograph is fantastic. Like I said, I get access to it every Tuesday. That's my Keratograph day, and I love using it for dry eye, the dry eye report. That, if you guys can, Oculus can somehow get a NICBUT on the Pentacam, I would be set for life, and I wouldn't need another instrument. I'd be good with just that. So if you guys can work on that, let me know when you got one ready.
Well, and I think a lot of it too, like I mentioned, I'm a cold start, so I'm starting from 0 patients and going up, okay? You don't really know how many people are going to need a Pentacam. I'm also lucky enough to be in the Metro Detroit area, where I am surrounded by really awesome ophthalmologists that have Pentacam. So usually every patient that gets sent to me has just had a Pentacam the week before. I definitely think if you're doing a lot of keratoconus management, someone needs to be doing that Pentacam, whether that be you or whoever you're co-managing with. So it just depends on your proximity, where you're practicing at. If you're more rural, like if you don't want to send someone 2 hours to get a Pentacam scan, it might be something that's worth investing for your practice. But also just like group versus solo. I mean, Trevor is a Pentacam, but he also has how many doctors working for you that use it? You got
We have 8.
You have 8 doctors,
We have 8.
right? So if you have 8 doctors and maybe an ophthalmologist and a LASIK surgeon, you really have to look at your individual practice and what your focus is. My focus is myopia management, dry eye, specialty contacts. Trevor sees a lot more really awesome, scary disease stuff that I don't want to see, okay? I don't want to see these crazy ulcers and these ruptures and all the stuff that he's seeing. That's great. That's his practice. That's his passion. That is not my passion. That is the passion that I send to my great colleagues right down the road that can do that. So you really just have to look at what's best for you. As far as like cash flow and practice debt, you have to think about that. At least I have to think about that, because as my solo practice owner, that cash flow and practice debt is my practice debt. Sometimes if you work for a hospital-based or school-based practice, it's something you might not have to think about as much, but it just depends. But the great news is both of these are really great tools. So it's just a matter of what fits the best for you. Anything else to add with that, Trevor?
Yeah. No, I think, like you said, they're just, everyone's got a great, spot for either one of these, I think any of us could agree if we had the opportunity to have both in the world, it'd be wonderful all the time. But I'm lucky enough to at least have one on Tuesdays, but the one the other day. But really, it comes down to just the type of practice that you're in and being able to utilize it that way. So, and with that, I think we're at an end. So I don't know, Michelle, if we have any questions and things like that here.
We do have quite a few questions. I thought I might ask just one question to each of you, if that works. All right. I just wanted to say, just a reminder, if you do have any further questions from the audience, if you do want to submit those, I can always pass along those questions to Dr. Fosso and Dr. Kuzniar, and I'd be happy to forward those responses on. If you missed part of the webinar, or if there's anything you'd like to go back and review, you will receive a link to the recording the next week. All right, I'm going to go ahead and just ask each of you one question. And Dr. Kuzniar, my question for you is, how do you approach scheduling both dry eye and specialty contact lens fitting? Do you do them on specific days to kind of help maximize that revenue that you're doing? Is it kind of a mix each day?
So at my current practice, my original goal was to schedule one day of all my specialty lens fittings when I first opened, because I just assumed if I opened up cold that I would have a lot more primary care patients. I was wrong. I have a lot more specialty lens patients. So mine right now are just kind of intermixed. But I started out when I was still growing, trying to have all those specialty lens patients on Wednesdays, for example. That way you can really just get through and your brain is focused on doing specialty lenses. You're in the rhythm, you're in the moment. You don't have to worry about a glaucoma workup or, a routine exam in between. Trying to get all of those through. Now I'm kind of more intermixed. I was at a group practice where I was doing more dry eye as well. So I would actually have half days where I would only do dry eye, either in the morning or the afternoon. So really it was just dry eye after dry eye after dry eye. We'd have a technician that would do any of the lipoflow or procedures there if they wanted to, like same day. So we kind of set up our clinic that way. So it just really depends on what type of clinic you're in. And if you listen, Trevor does them on Tuesday. So Trevor does his dry eye on Tuesday. So I think it is easier if you can block your schedule that way for your staff and for yourself as well.
All right. Thank you for that answer. All right, Dr. Fosso, are there any go-to displays on the Pentacam that you use for patient education or to kind of help show a patient that maybe moving forward with a specialty contact lens would be best for them?
For me, it all depends on their condition. Like I said, the four that I showed, the general overview, the Bell and Ambrosio, the four-maps refractive, and the topometric keratoconus staging. The Bell and Ambrosio enhanced ectasia I do on all my LASIK evals. The other three are the three that I get on every single patient that I get a Pentacam on. Those are the three my technician knows to send over. And then I utilize those, depending on what I'm looking at. If I have someone who has, I'm like, oh, I'm concerned of keratoconus, then I look at the KC staging one. If I'm concerned of, like a transplant or something else just kind of funny with their cornea, the four-maps refractive is usually my favorite. If I'm fitting them with a scleral lens, I show them the CSP scan that I got of their eye to say, like, here's the shape of the front of your eye, and we're going to basically contour the lens to fit how this, to fit this shape here. We do a comparison map too for ortho K patients. And so, I always show that to my patients, the kids, their parents for ortho K, just to say, like, yep, everything's looking nice and centered, everything like that. But I would say really that general overview, the 4 maps refractive, and the keratoconus one are the 3 that I look at the most and on those patients.
All right, thank you for that great answer. And thank you, Dr. Fosso and Dr. Kuzniar, for the great presentation. That is all the time we have for tonight. Thank you for everyone who sent in questions, and thanks for joining us. Any last thoughts?
No, thank you all for joining us. Hopefully the weather's still, I know, maybe a little sunny outside for people. It's getting kind of late-ish here, but not too bad.
Here on the East Coast, look how dark my camera got so quickly. But thank you everyone for joining us. If you have any questions, feel free to email either of us as well, especially in regards to like practice management. Like both of us have been using these instruments for years. We really believe in them and stand by them. So just we're an open book. But thanks for having us tonight.
This concludes the presentation. On behalf of Oculus, good night and thank you.